The next moderator, Dr. Humaira Mahmood.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I'm sure all of us are struggling hard to keep ourselves awake in the post-lunch session, but don't worry, this is going to be the last talk before coffee break. So the talk is related to oligometastatic disease, which is important in the sense that it has got the potential to be cured, as it's an intermediary stage between the localized curable disease and polymetastatic disease, which is treated with palliative intent. So we are going to hear about the role of SABR from clinical evidence to global practice for oligometastatic disease, to be presented by Dr. Mutlay Sayan, who is an assistant professor of radiation oncology practicing at Harvard Medical School. And his areas of expertise are genitourinary breast cancers and pelvic nodal radiation and hypofractionation. And he has got a number of publications under his name. So please, Dr. Mutlay Sayan.
Perfect. Hi, everyone. Thank you so much for the invitation. As I was introduced, I'm Mutlay Sayan. I'm a radiation oncologist at Harvard Medical School, and I'll be talking about oligometastatic disease. In there's no disclosure, but full disclosure, I specialize in prostate cancer, and so the talk is going to be very heavy on that. When we think about the burden of the metastatic disease across all cancer type, it's very significant. Like more than 90% of the deaths, cancer deaths, are due to metastatic disease, and treatment in the metastatic setting historically has been palliative and geared towards the prolonging survival and kind of improving the quality of life. And because of that, the standard of care for metastatic disease has been traditionally systemic therapy, kind of reserving the radiation treatment for the palliation of the symptoms. I think it is important to look back and kind of see how our treatment has evolved in parallel with our understanding of the cancer itself. Over 100 years ago, Dr. Paget, proposed the seed and soil hypothesis. It's based on the biopsy, based on the autopsies of the breast cancer patients, actually, and looking at where the disease were going. And he saw that some of the organs will have multiple metastases, such as liver, but the other one was not having any metastases, such as spleen. And he concluded that, saying that when a plant goes to seed, its seeds are carried in all directions, but they can only live and grow if they fall on a congenial soil. That kind of set the stage for the treatment at that time, that the surgical removal of the all known disease was attempted. Now, of course, our understanding of the cancer has evolved over the years, and now that we know that the nodal involvement is a marker for this, the metastases, for example. And what has changed is that we have better technologies, that we are able to look at the cancer at a cellular level, understand the mechanism and changes that is leading to the cancer development and progression. And this is important because that kind of sets the foundation for the systemic therapies and targeted therapies and how we can achieve synergy between them as well. In 1990s, two oncologists, radiation oncologists, Dr. Hellman and Dr. Waxelbaum, and proposed the idea of the oligometastatic state. And they reported that, for certain cancer, the anatomy and physiology may limit or concentrate these metastases to a single or a limited number of organs. And this is important because if the disease are limited to a certain organs only and retained there, then perhaps the treatment of these organs along with the primary will provide perhaps a cure. And this was very out of box, and this was very controversial when it was first presented. And even though it's currently quite accepted, but at the time that it was presented, it was very, very controversial. And I know Dr. Waxelbaum quite well from medical school, that and he still actually a chair at the University of Chicago. And I remember him talking about this over and over, even in the institution, to kind of try to convince convince other radiation oncologists in the field. But the important is that how can we achieve the maximum benefit, right? Like, what is the right patient and who's the right patient to treat? Perhaps this slide can provide us some guidance on this, and perhaps it can kind of visualize us to see it. And this was adapted from Dr. Pengula's editorial, and this was based on a local treatment for breast cancer patients, actually. And we call it as a sweet spot. What is the sweet spot for the SBRT for the for metastatic patients? As we see that as the effectiveness of the systemic therapy increases, the impact of the local treatment on survival increases to a certain level and then started to decrease. And the sweet spot will be at the middle of the center, that we can see that we are achieving the most benefit in here. The reason that is that our effect is decreasing significantly is likely due to the burden of the micrometastatic disease that we have, and we cannot treat all of it. Maybe it's another way of looking at this, that the iceberg analogy, that we can see that on the image, that the number of the disease that we are seeing, perhaps just what we are seeing in the PET scan or CT scan, whatever the imaging that you are using, that is the only disease that you are seeing. So if you were to treat what you are seeing, and assuming that that's the only thing that there is there, and that you that might be able to achieve the most benefit. And in some cases, maybe the cure, or at least delaying or giving patients some holiday from the systemic therapy, that can be quite toxic. In the opposite end of the picture, perhaps that you have multiple disease that you are not able to see it, and those settings that treating the metastatic side with the kind of like a SBRT, curative intent, and trying to get everything is perhaps not the best option to proceed, because as we remember from the graph, that is our impact is decreasing, and then perhaps the toxicity will be significantly higher. And in those settings, that perhaps reserving the radiation treatment for the true palliative intent, it might be the way to go. When we look at the ASTRO consensus definition for the oligometastatic disease, that they are defining it as up to 5 lesions. Control primary is an optional, but all the metastatic sites has to be treated safely. So up to 5 lesions, that's what we have been fixed on all the time. I remember even from trainings. But if you were to dig through this guidelines and then look at it, it's actually the true definition for the oligometastatic disease, that if you are able to deliver a safe treatment with a curative intent to all of the sites, that is the minimum requirement, really, not a number of the lesion, actually. I was just at the NRG meeting 2 weeks ago at San Francisco, where we're discussing the new set of trials that is being designed. And there was a huge discussion of a randomized trial that's being proposed, that allowing up to 10 lesions to be irradiated with SBRT in an intent of curative intent, which is, when you think about it, is kind of unheard of. Like 10, at least for me, it's 10 lesions. But some people are very quite comfortable with it, and because of their practice. At our institution, we are allowing up to 5 lesions, but I can see there are discussion maybe treating 6 or 7 lesions, depending on the locations of them. There is a huge interest in oligometastatic disease, and that is reflected on the number of patients, a number of articles that has been published. And this is I just looked at it quickly on a PubMed, and how many, when we look at it, how many papers that have been published with the oligometastatic in their keywords, and we see that it's quite high. Majority of these papers are unfortunately retrospective in design from single institution, but there's a great interest. And why do we have such a big interest is in SBRT and local treatment, is that now we have new, more sensitive methods of cancer detection, that we're able to detect patients with the limited number of metastases. Like, I get PSMA PET scan pretty much for every high-risk patients, that once in a while that I will be seeing some oligometastatic disease. it provides local control has become more and more important as we have improved systemic therapies, that the patients are living longer, and if there's any oligopersistent disease, which I will get into it in a bit, that perhaps providing we're seeing those patients. That's why it's becoming very important. The other thing is that our technology has advanced. Like we've been hearing since yesterday how the radiation is more advanced, and I'm sure Dr. Atullah is going to talking about the MR-Linac and how our technology has evolved, that we're able to deliver more safer, more precise treatments. And the potential benefit of using SBRT, there's multiple things that we can go over. I think that what I see the most important thing is that perhaps in the clinic is that we're able to delay or systemic therapies or give patients some holidays from systemic therapies. For example, when they are getting a really, when they're getting ADT hormone therapy, perhaps we can able to give them a holiday from the hormone therapy that's routinely done in our practice. It can eliminate resistant clonidins, in which I will show a photo of it. And then there's a potential systemic therapy benefit that our colleague just mentioned about it in the lung cases. And there is also, you are able to improve the quality of life through prevention of local progression. Even if you were to think about, the Piece 1 data was presented last year, that if you were to do the SBRT to the primary site even, in the high volume setting, that you are able to kind of delay the progression or provide local control, delay the serious GE events to happen. And perhaps in the selective cases that we might be able to provide cure as well. In terms of terminology, for synchronous metastases that I see the most, the de novo presentation, the patient just walks in with a limited number of cancer diagnoses they've just diagnosed. And oligorecurrence is that they had their cancer diagnosed, and then they have now the oligometastatic disease that controlled primary. Primary has been controlled, but they just have some disease. And oligoprogression is that the limited number of metastatic lesions progress while on their side remains stable. The oligopersistent disease is perhaps the second most common thing that I tend to see, is that the limited number of metastatic lesions persist while on systemic therapy. And these are, I think it's very important clearly that systemic therapy is not working on these lesions, and if it's a limited number of lesions, that you might be able to provide SBRT to those. Just to delve into some trials, the SABR comment that we all know about is that included patient with the 5 and less metastatic sites that was randomized into the palliative RT if indicated versus the SBRT. They included multiple primaries, and the primary endpoint was the overall survival. And when we look at the baseline characteristic of the patients, that we see that they were breast cancer, colorectal, lung were the most the most common ones. They also had prostate cancer, but strangely enough, many of them actually ended up getting the SABR. Even though they allow up to 5 lesions, it was beginning of the, this is one of the very earliest trial that perhaps people were a little hesitant to SBRT up to 5 lesions, as we see that now that there's majority of the lesions were up to 3. When it was first presented that there was a sign of the overall survival benefit with the longer follow-up, that became significant. And now there's an overall survival benefit with the SBRT compared to a control arm. And progression-free survival was also significantly improved, and that was kind of carried out over the long follow-up. About 30% of the patient ended up receiving a salvage SABR. The interesting part is that there is no difference in time to new metastases. That is likely from that these patients probably had been seeded at the time of SABR. Important to note that there were 3 people experienced death due to treatment-related toxicity. One was radiation pneumonitis, another one was pulmonary abscess, and the other one was subdural hemorrhage when they were trying to repair the perforated ulcer. And that kind of tells us that how important it is the patient selection and the location of the tumors, and this should remind us that. And for the prostate cancer patient, that I want to mention a couple of trials that one of them the STUMP trial, and that allowed up to 3 metastases that the patient were randomized SBRT versus surveillance, with the primary endpoint being ADT-free survival. ADT-free survival, as we would expect, that significantly improved. And the important one is that as we see that there is not really a local progression or symptomatic progression on the arm that received the SABR. An Oriole trial from Johns Hopkins had a similar design, up to 3 lesions, again, SBRT versus observation, and the primary endpoint, the progression at the 6 months, that showed that the progression was actually significantly improved with the SABR, and they are currently doing some fancy genomic analysis in this trial. And the most recent trial is the Extend trial, that now that we have up to 5 lesion, and also the patient were either had ADT versus ADT plus SBRT, and the primary endpoint was the disease progression. And the combination treatment actually, as we would expect, that the progression-free survival was significantly higher in that group, the median progression-free survival being 22.4 months. Out of my comfort zone, when it comes to the breast cancer, there's a 2 trial. One is the NRG. Dr. Kumar actually presented this in ASCO 2022. I don't think the paper is out yet. And the other one is the Extend trial. And both trial actually did not show any progression-free survival benefits, strangely enough, but the SABR comment had an overall survival benefit that included the breast cancer patients in it. So that even though there's the 2 trial, one is not fully published, the other one's published, that's not really showing it, but I can see that in the practice that the selected patients are being treated with the, SBRT. We need more trials, and more trials are coming. There's, selected some of the ongoing trials that perhaps these are going to help us even further to define the who's going to be benefiting from the SBRT and who's not, and what is the best patient population. In terms of conclusion, the oligo-metastatic disease represents a biologically and clinically distinct state between the localized and widely metastatic cancer, and perhaps there's they have a room that we might be able to provide some significant benefit, actually. The local benefit of therapy depends on the careful patient selection, disease burden, and time of the presentation. And ongoing and future randomized trial will define the benefit, who's going to benefit the most, and when to intervene, and how best to integrate the SBRT. I thank you so much. This is my email. If any questions or concern or any collaboration that would like to be engaged.
Thank you, Dr. Sayan, for your wonderful presentation. I think we can have just 2 questions, and then we'll have coffee break.
Oh. Great question. Great question. If what I see the most, like I see this very often because we are a center that all people comes from second opinion. Like I treat only like less than 20% of the patients that I see, and the ones that I see, it's very complicated, and the case like this will always comes in at least once or twice a month. If they are having, there's a few things that one must do. If they are at least at our institution, if they had a recurrence within the prostate after the radiation treatment, and there's 3 things that must be done. One is that the one has to get a PSMA PET scan to confirm that is, there's an uptake in the prostate. And the second is that one has to get an MRI to kind of confirm that. And the third thing is that our brachytherapist specialist will not touch any patient if biopsy has not been done. And then they will get a biopsy done. If these 3 steps has been completed, then I will refer them to our brachy specialist. And brachy specialist will treat them actually, sometime the entire gland, depending on the extent of the disease. Sometime, and they will always do HDR brachy. And sometime if the patient has very localized disease in the tiny edge of the prostate, or they are having a lot of urinary symptoms, and they will place just some needles in that area and deliver brachytherapy. And the question of whether to use ADT or not ADT in those settings is up in the air. There is not really a right or wrong answer to it because there's not really a good clinical data to kind of support one way or another. What I see is that often that medical oncologists will tend to put them on 6 months of ADT, depending on the age of the patient and their desire and how aggressive they want to be. When it comes to in the post-op setting, assuming that we are referring that the post-op that they had radiation treatment post-op, and then there is a recurrence in that setting, that becomes kind of little complicated, right? That's not, if it is really within the prostate bed that is easily achievable, that one would probably try to do an brachytherapy again and place some needles, because then you don't have any of those spillage to other areas. If not, we would probably do an MR-Linac based an SBRT to it. And you must have the prior radiation plan and kind of look at the dose constraints and kind of come up with a dose that is safest to deliver. And that can be different from patient to patient. And, you know, one patient, you can go high up in the dose depending on where it's coming. And if it's not, then you kind of have to go, you have to respect the tissue and kind of decrease your dose. So you have to, great question, wonderful question. Because of your fractionation is going to be different, you have to convert everything to 1.8 gray for fractions and do a calculations and use that rather than just using the SBRT constraints, or rather than just using whatever the constraint. You have to convert everything to a 1 so that you can safely compare. Otherwise, it will be very difficult. And I'm more than happy to send me an email. I'm more than happy to explain that and what are the steps that we would do. There's one more thing. There's a third scenario that was in the prostate bed, right? That was recurred. If it were to recur in the lymph nodes, and assume that the patient somehow did not get lymph node radiated, because the SPORT trial R2G0534 tells us that we must treat if we are treating the prostate bed, we must treat the patient's lymph nodes too. Hypothetically speaking, if the patient did not get their lymph node treated and now there's a recurrence in the lymph node, and the question comes, whether do you do the SBRT to that tiny little node, or do you treat the entire lymph node chain? And the answer comes from the SMART trial that was presented recently. And that tells us that you should not be doing the SBRT to those, and you should be doing the entire lymph node chain to, depending on what you are comfortable with. And at our institution, we would do 50.4 gray in 28 fraction, and we will boost that whatever lighting up to 61.6 gray again in 28 fraction. The key in that setting is that you must have the prior plan and kind of end in your lymph node field should end in a way that it's not overlapping with the prior radiation field. Otherwise, you're going to be, that area might end up getting almost 100 gray if you are not careful with it. So that requires kind of working with your dosimetrists or physicists to make sure that it's safely delivered, but definitely not SBRT on that setting, at least at our institution based on the SMART trial.
So is there any other question?
Okay.
I have one.
Please.
Is there any evidence of repeating SBRT for metastatic lesions in brainstem?
Repeat. There is not really. If I can see that some people will say that, well, it did not respond the first time, I don't think it's going to respond in the second time. That is the assumption that you did not miss your target, right? If you were to miss your target, probably, if you are very confident that you did not miss your target, then I would say probably not. But there's not really there's not really data to show it that I know of that based on this study or that study. It's a difficult situation. I'm so sorry that I don't have an answer to it. The brain, I know. Yeah, the brain, I know. The brain, you can do it. Rate.
Brainstem. I was talking
Oh, brainstem.
specifically about brainstem.
Oh, brainstem. It's so away from prostate. Brainstem. When I was a resident, I did a paper with Banato. Actually, she's left. Not the brainstem, but the brain itself. I know that you can re-rate it. I can find out if you would like. Send me an email. I'll find an answer for you. I'll ask our specialist. Kids would do it, yeah.
I mean,
They
and the
want me to leave, I
brainstem,
think.
I can answer. I mean, from my experience, I mean, although I mean, I'm doing CNS, so and the brainstem, it depends on the location, and then usually, you know, like after 2 years, we calculate that there is we are assuming that there is a 40% recovery of normal tissue, and then we need to calculate. It's challenging. It's not easy, but somehow we can.
Yeah.
Not on the same, maybe, and it depends on the level. Yeah.
It's different. Right. No, there is no. I wish I knew it. Well, thank you so much. Thank you.